Good morning. First of all, I would like to thank Professor Serene and Dr. Seema Alam to give me this opportunity to talk on a subject which I think is of common relevance to most of us, not only anesthesiologists, but hepatologists as well as the pediatric hepatology as well. And as we all know that number and complexity of GI procedures are increasing every day. The census of 2017 in US state that 50 million endoscopy procedures were performed, and which includes 19 million colonoscopy. Use of anesthesiologist administered propofol for low risk endoscopy, especially the colonoscopy in USA, is estimated to cost an additional $3.2 billion over a period of 10 years. That is the very expensive course, and the cost of primarily because of anesthesia. I shall be talking on this following contents: anesthesia goals, preparation of the patient, pre-procedure assessment, monitoring, anesthesia technique, complication, innovation, our research projects which we have conducted here, and further research which we are planning to have it. The basic goal of anesthesiologist intervention is that patient point of view, patient should be comfortable, he should have a hemodynamic stability, there should be no fluctuation of blood pressures, and there should be intact airway, and airway reflexes should be intact, and there should be no respiratory complications, and easy and safe post-procedure discharge. From endoscopy point of view, it should be a smooth procedure, and there should be minimal hindrance to the endoscopist. Patient with significant comorbidities and patient who need some therapeutic procedure need to be admitted, and otherwise patient can go home, and get outpatient who are not very sick, they can go home, but we have to make sure that there will be somebody to take care of them at home. Informed consent should be obtained in all the patients. Fasting guidelines is one of the most important part of our preparation for these patients, and the fasting guideline has been laid, and it is clear fluids can easily be administered 2 hours prior to the procedure, prior to general anesthetic. Clear fluid means it should not be particulate fluid, like water, apple juice is fine. However, for normal meal, the light meal, the fasting period can be up to 6 hours. For fat and Friday meal, it is about 8 hours or more. However, there are no standard pre-procedural fasting guidelines for GI endoscopy. The gastric empty is of course impaired in emergency situation, and risk of aspiration of gastric content must be considered in determining the level of sedation, and procedure may be delayed if the patient's stomach is full, and airway should be protected by endotracheal intubation. Routine prescription NPA, which we usually write, extends beyond fasting hours for 10 hours. And it has been seen that prolonged fasting though will be best for proper visualizations, and also reduce the risk of pulmonary aspiration, but prolonged fasting does have various adverse effects, that it causes weakness, thirst, anxiety, and also it is not good for elderly patient, where it can lead to nutritional, fluid, and glycemic imbalances. This was a randomized study where preoperative fasting was overruled. With the patients were given oral dehydration solution containing carbohydrate 2 hours and 4 hours prior to the endoscopic procedure, and it was found that None of the patient had a residual gastric volume for more than 1.5 liter in 4-hour group. However, in 2-hour group, about 10% of the patient had fasting, which was not acceptable. And besides this, that other parameters like thirst, hunger, mouth dryness, and was much lower in 4-hour group compared to the routine elective patients who are fasted for more than 8 hours. This study indicates that avoiding preoperative fasting with oral carbohydrate administered fluid 4 hours before anesthesia can easily be achieved in cirrhotic patients, so we do not need to keep them fasting for more than 4 hours. Our data, which we studied in this month from 1st June to 28th June, and we enrolled 258 patients. The average fasting time in our patient ranged from 6 hours to 20 hours, and mean time of NPO was 13 plus minus 3.2 hours. Further, we found out the symptoms and asked them what symptoms did they have. Dry mouth was the most commonest. Then it was seen in 22 patients out of 74, and followed by headache, nausea and vomiting. So overall incidence of adverse side effects in our patient was close to 28%. The common procedure which we performed are esophago-gastroduodenoscopy, when the esophageal varices bleed, bending, colonoscopy, sigmoidoscopy. And other complex procedures are ERCPs, ultrasound-guided EUS, esophageal stent dilatation, and enteroscopy. Pre-procedure assessment. Pre-procedure assessment is very essential for our daycare patients, because most of the time, because of haste, because of a lot of rush of the patients, and this part is generally missed, and it has been seen that patient has been brought to the endoscopy table with full stomach, and also they have a history of some comorbidity like cardiac and respiratory issues, and many times we have seen have to be cancel the patient because they have a history of obstructive sleep apnea and they were very obese, where proper history was not taken. Examination is equally important. Though should be a quick examination of all the vital signs, neck mobility, and Mullen-Putty scale grade of difficulty of intubation should be assessed, so that if case there is any issue, or if the patient need endotracheal intubation, we are very well prepared about their airway issues. Other most important thing is when we evaluate the patient, we need to do a stratification of the risk, which is this is the American Society of Anesthesiology class. The increasing class 1, 2, 3, 4, 5, and 6, and means there is an increased possibility of cardiopulmonary events. Most of our cirrhotic patients come under ASA class 3, that is the patient who are suffering from systemic disease, moderate to severe. And when they get decompensated, their severity of illness and their severity of problems enhance, and they come under class 4. We do not need too many investigations. All those investigations which has been done by the unit which is going to plan the procedure are usually adequate, and no further investigation is needed from anesthesia point of view. But we need to have adequate monitoring. There are standard monitors like NIBP, heart rate, blood ECG, oxygen saturation. These monitors are needed for all the procedure, but there are some patients which will require end-tidal carbon dioxide monitoring, depth of sedation, and invasive monitoring, including the we have placed many times a intra-arterial catheter for monitoring the cardiac output, and for not cardiac but the blood pressure invasive for patient with significant cardiovascular disease. Different societies have recommended various different monitoring parts, but NIBP and pulse oximeters are still standard. Capnography can be considered in some patients, but of course for GA they are all needed. ECG, from the lot perspective, we found that ECG is not routinely, though we use it for all the patients, but in fact it is not needed for all the patients and can be avoided, can be used only for selective patients. BIS index, which we have also been using for many times to find out the depth of anesthetic, and it has not been found to be of any great advantage and doesn't give us any additional information, except that sometimes the doses can be reduced, and hence is not recommended for most of the endoscopic procedures. Various anesthetic techniques which are employed in our setup are topical anesthesia. It is in the form of spray, swab, or giving some lotion for local anesthetic solution for gargling. And topical anesthesia is still very much practiced in many parts of European countries and even in our country, especially in those patients who do not have significant systemic illness. Intravenous sedation is the most preferred, and sometimes this patient need to have a general anesthesia, and a combination of these techniques can be followed depending upon the type of condition of the patient. This was one study where they compare the effect of topical anesthesia by two ways. The lidocaine spray is the one which we are commonly used many times. That we it is a 10% spray, contains about one spray contains about 10 milligram of lidocaine. 5 to 6 spray sprayed with the help of a laryngoscope or a tongue depressor 5 minutes prior to procedure was compared with the viscous lidocaine, 5 to 6 ml of the solution given for goggles, and asked the patient not to swallow. And the procedure was esophageal It was found that lidocaine spray was found to be much better, and as a tolerance and ease of instrumentation was much better with spray compared to lidocaine viscous. So lidocaine spray, which can easily be given, was found to be more useful compared to the viscous. Further, their study, they found that if you go more close to the posterior part, and this was another study they did about posterior lingual lidocaine swab, which probably will block the glossopharyngeal nerve, and use a lidocaine is directly applied to the base of tongue and the peritonsil fossa, and they concluded that this was found to be even much better than lidocaine spray. So topical anesthesia has minimal adverse events. Patient can communicate. It has a short recovery time. It is cost effective, and it is suitable for ambulatory case for ASA1 and ASA2 patients. Main disadvantage is that many patients are not satisfied. They find it traumatic. Endoscopists are not comfortable. And of course, it's not good for pediatric patients or patients who are not cooperative. It is primarily because of these two factors. Most of the places, especially in USA and including in our center, we adopt to mild to moderate sedation even for minor endoscopic procedures. Intravenous sedation is the one which is most commonly given, and there are various drugs which have been widely used. Out of the hypnotic agents are usually used for induction of anesthesia, as propofol is the most promising drug and is widely used all over the world. Ketamine, etomidate, and dexmedetomidine is now coming up. The benzodiazepine, midazolam, is the most popular and is being used widely by all the endoscopists as well as by the anesthesiologist. the level of sedation in these patients need to be a deep sedation or analgesia. But if you need a deep sedation and analgesia, this patient may have airway patency may be compromised and may require intervention of the airway, and even respiration need to be monitored very closely because it can sometimes be inadequate. The various drugs, I will just give a brief description related to endoscopies. Fentanyl is the most potent analgesic, has an immediate onset and does not cause hypotension, is very popular with most of the anesthesiologists and also by the endoscopist, and it is a good choice, especially in the very sick patients. However, propofol still remain mainstay in the sedation for endoscopic procedures. It is very potent. The onset is rapid, recovery is fast, and patients usually wake up soon after stopping of propofol infusion, and there is no hangover. It causes clear-headed recovery. But it has a very narrow therapeutic window. It is known to cause severe hypotension in some patients, especially the elderly, or especially those who are dehydrated, or especially those who have, there is more follow-up blood pressure if the patient has been fasting for more number of hours. Can cause bradycardia, cardiovascular depression, respiratory depression, and myocardial contractility. That's why propofol should not be administered by the non-anesthesiologist. Other drugs, ketamine is another drug which is very useful to us, especially because it does not have any cardiovascular or respiratory depression effect, and it is a potent analgesic and has been found to be very useful in patients with shock or where there is a critical ill patients. Midazolam, of course, you all know, is one of the most common drugs used by the endoscopist. It has been found that one must understand that midazolam main metabolism is by the liver, and it has been, when it was started, everybody thought we got a wonder drug, but it has a very unpredictable actions from patient to patient, and extra dose of midazolam has also found to cause a lot of morbidity and mortality when it was started to be practiced. So one need to be very careful in administering the excessive dose of midazolam, especially in our patients who have a liver impairment, and many times the effect is very prolonged. So when to administer general anesthesia? The main indication for general anesthesia is when the patient had a cardiovascular and respiratory instability, patient have full stomach, and they are morbid obese. Now there was a study to find out whether the general anesthesia is better or sedation is better. In this study, retrospective study from Germany, they have evaluated 17,538 patients, out of which the sedation versus general anesthesia was compared, and it was found that adverse events were occurred in 5% in patients who were sedated compared to 16% of the patients who were administered general anesthesia, which otherwise could have been done under sedation. They have enrolled healthy patients, ASA 1 to 2 patients, where general anesthesia was not clearly indicated. So the study suggests that, the results suggest that the use of sedation during ERCP facilitates the reduced adverse discharge for patients for whom general anesthesia is not clearly indicated. If general anesthesia is not clearly indicated, it is better to give sedation, otherwise they will have adverse events. Now, on the contrary, if the patient is a high risk, patient who is obese, has a body mass index is more than 35, has a COPD, and has a difficult airway and Mallampati score is 4, and also is using moderate to heavy use of alcohol, it has been found that in those selective patients, general anesthesia is found to be much better as compared to sedation. they studied about 200 patients, and it was found that when sedation was given in these sick patients, 10% of the patients there was interruptions and they were need to be converted to general anesthesia. So in this group of patients where patient is having a lot of morbidity, general anesthesia is better compared to sedation. Now we must have the resuscitative equipment should always be available and it should be handy, and it has been found that many times we have the patient on the other side of the table where the equipments are not available. There have been instances where we need to ventilate the patient, give them positive pressure ventilation, but the connector and the airway and the tubing were far away from the patient's site. So all these things should be taken into consideration because emergency can happen anytime. Now the big questions in USA because of the heavy cost of anesthesia and anesthesiologist fees, which many times it's more than the endoscopies. So most of the endoscopy private center are very much concerned about paying to anesthesiologist. So they have the nurse were trained, but nurses were not found to be good for sick patients. The nurse was only good for ASA 1 or 2 patients, but they still need supervision as long as anesthesia with propofol is required. So as for the FDA, propofol is not to be administered by non-anesthesia personnel. Also there was a computer-assisted propofol sedation which was to be given by the clinician, that is the endoscopist, and this was found to be very promising device where computer could give the sedation, but since there was difficulty in coordination and the sale of this gadget was not enough, so company stopped manufacturing this. So still then ultimately endoscopists have to depend upon the anesthesiologist for administration of anesthesia. And who required patient and procedure factor when anesthesia is required. As I already said, the sick patients, ASM 43, difficult patients, multiple comorbidity should be anesthesia should be administered by the anesthesiologist. Upper GI endoscopy. The main stimulus in upper GI endoscopy is the gag reflex, which need to be obtended. The afferent is glossopharyngeal and efferent is vagus nerve, and for various sedative need to be given to blunt the gag reflex or midazolam, followed by small doses of propofol, and if the patient is still not settled, then one can give a small 0.5 to 1 microgram dose of fentanyl to obtain the reflex. When we give the sedation to these patients, we are sharing the airway with the endoscopist. Many times they need jaw thrust, chin lift, and we need to ventilate the patient, and if the patient is not breathing adequately, then advanced airway like LMA or endotracheal tube need to be inserted. Colonoscopy is not cause too much of issues, and we can give it a small dose of midazolam and a few milligram boluses of propofol if the patient is moving. Now ERCP is one of the main procedure which is a big concern for the anesthesiologist because many times patients are in a prone, semi-prone position, and one has to decide whether to give general anesthesia or deep sedation. There are various stages of ERCP. Patient had a stimulus that when there is a scope is inserted, they get stimulation when we need to blend the gag reflex, and scope manipulation during cannulation is painful, needs increased dose of anesthesia. Ballooning of biliary tract, again increased dose of anesthesia is needed, and if cautery or biliary opening is done, this also is painful, required further increased depth of anesthesia. These are the standard monitor we use. Many times we can use the BIS monitor, but it remains optional. we devised this very simple technique to monitor end-tidal CO2 that which was, we thought that when the patient mouth is open, it is not possible to monitor the end-tidal CO2. So we devised a technique where was a routine suction catheter of 14 to 16 gauge which was introduced to one of the nostrils and was placed and fixed at a place when we get a good trace of end-tidal CO2, and we found that this simple technique was very useful at times when we need to monitor end-tidal CO2 without any interventions. So that's the standard protocol for sedation. If the patients are sick, we should give diclofenac and xylocaine spray, which will reduce the doses of our anesthetic drug, midazolam as well as fentanyl or propofol, and then usually they are maintained under TIVA, infusions of propofol. Rescue procedures are needed. We need to, many times the patient jaw thirst, a chin lift is needed when the saturation drops less than 92%. And we need to, many times, if the patients are obese, then it's better to put in a nasal trumpet or a nasal airway, which maintains the airway patency as well as better oxygenation and better monitoring. So this was another study which compared the anesthetic complication with the gastrointestinal complication. It was found that this is a study for 10-year study of ERCPs. 1,023 patients were studied, and they found that hemodynamic stability in this study was 37%, and desaturation occurred in 11.6% of the patients. Prevalence of GI complication was much lower, it was mainly pancreatitis and bleeding, but since the anesthesiologists were readily available and this patient could easily be resolved, so presence of anesthesiologists is very essential when we are given sedation to resolve these complications. Morbid obese patients carry extra risk because they have a sleep apnea problem. They are very sensitive to anesthetic agent, and they have a minimal their cardiac reserve is also compromised. So it is very, these are the patients which can be very difficult to anesthetize, especially in prone or semi-prone or lateral position. So we need to be extra careful while giving the anesthetic agents, and it is better to give them NSAIDs and lidocaine spray, primarily to reduce the dose of anesthetic drug like ketamine or propofol. Ketamine and propofol, or the combination, is found to be very suitable because it does not cause too much of respiratory depression. In this study, they evaluated 119 patients who were very morbid obese. BMI was more than 40 per kilogram per meter square, and they also had other various issues. And they found that a simple procedure maneuver of putting a nasopharyngeal airway as a preemptive before starting administration was able to have better outcome in these patients. Pediatric, basically we need to make sure that pediatric patients should not be made to fast for a longer period, and they can the clear fluids, water, fruit, juice without pulp should be given 2 hours prior to the procedures. General anesthesia for pediatric patient needs very expertise. Patient should be there, and if patients are not expertise in handling the emergency situation of sudden fall in saturation or airway obstruction, or if the patient needs intubation, it has been found that those patients should not be given sedation because if the anesthesiologist is not very well aware of handling the situation if there is an issue. So, in fact, one of the studies said that in those small kids who are weight less than 5 kg, less than 6 months of age, general anesthesia planned general anesthesia is more safe than giving sedation to the pediatric patients. Various innovations which have been now been introduced. This is a multi-center study where they use a high-flow nasal oxygenation, which we have been very popular in patients with during the COVID time. We had used it, and they compared it with routine oxygenation at the nasal trumpet, and found that the the patient at risk of hypoxia. This was used for sick patients who had a high risk for hypoxia, who are obese, and who are 60 years of age, and they have underlying cardiac and respiratory illness. In those patients, high-frequency nasal oxygenation was found to be useful, and most of the patients were they did not come across any hypoxic or any other event. Other innovation in endoscopy is a LMA gastro airway. This LMA has been introduced for last 35-40 years, and this is a special LMA where there is one outlet for ventilation and oxygenation and monitoring. The other outlet is to put in a scope. And this study, one of the research articles where they did studies that LMA gastro was found to be useful and was safe in 98% of their patients, and their endoscopists did not find any difficulty in inserting the LMA gastro. But we got 1 or 2 samples for trial at our centers, but many times I think we were not very much happy with this, and that need to be looked into. So a new drug, remimazole, in phase 3 trial, this drug medicine is something like midazolam and remifentanil, has been used by the endoscopist for colonoscopy. A large multi-center trial suggests that this drug, remimazole, can be administered safely under the supervision of endoscopists for outpatient colonoscopy, and it allows faster recovery and no neuropsychiatric dysfunctions. So this drug is a very promising drug, and it can be found that this drug can be used by the endoscopist without any adverse event because it does not cause too much of respiratory and cardiovascular changes. Fast propofol may be another version of propofol, might replace propofol because of its advantage of less pain in injection, water soluble, and less dose dependent issues which are there with propofol, like hypotension, apnea, and respiratory depression. Ketofol is a combination of ketamine and propofol, is found to be safe in obese and patients with a difficult airway. We did 2 research for that. This was a paper. We use a BIS-guided sedation for ERCP. A randomized control trial is under publication, was presented in the Scandinavian Journal of Scandinavian Conference in Copenhagen, and we found that pre-procedure administration of diclofenac sodium and topical anesthesia with spray and a BIS-guided was found to be safe and effective method in propofol, providing propofol sedation during ERCP and patient awakening, patient cardiovascular changes, and other parameters were found to be better when this combination was used. Other recent study which we have done is a etomidate. Etomidate is one of the very good anesthetic agent, and it doesn't have any cardio or respiratory issues. And this study was compared with propofol, the most commonly used anesthetic agent, and it was found that etomidate maintained better hemodynamic stability. Respiratory response was much better as compared to propofol. But some patients do have myoclonus, and one need not to exceed the dose of up to 60 milligram because it can lead to cortical suppression. So the work is going on for finding a drug like etomidate for patients who have basically the cardiovascular issues. While summarizing, I will say that fasting guidelines need to be properly followed. Diagnoscopy can be done under sedation or topical anesthesia. Propofol is the drug of choice. ASA3 patient needs intensive monitoring and to be done by anesthesiologist. And etomidate may be preferred or propofol for cardiac and elderly patients. And prompt management of complication is key to the safety of anesthesia for these procedures. We are planning to study these 2 or 3. One is that we are going to continue the audit on preoperative fasting, which is one thing which we have to improve at our centers because many of our patients are fasting long hours, even up to, as I said, to 20 hours. So they may have, and 30% of patients have issues with that. So this part need to be worked on. And also we need to find what are the safe anesthetic drug and combination drug like etomidate or propofol to be used in the sick patients for having better outcomes. I thank you all for your patient hearing.